And I don't know how much chance you'll get to do these various things downstairs. We're still working that out in the hands-on. I'd like to go over with you some of the ideas and techniques around acute stroke. It's something personally I'm very passionate about. We're not the busiest center for acute stroke, but we're relatively busy, and I think that you can't go into this space, you can't go into neuroradiology, interventional neurology, or neurosurgery without having some component of your makeup being excited about acute care, being excited about the patient comes in, they're extremely sick and devastated, and you take steps and make adjustments and provide care that makes a dramatic difference in their life, and that they live or die on. That's what we do. We deal with live or die disease states, and that's what acute stroke is, and it's very satisfying in that way. So, briefly, these are my disclosures. Therapy and positive or randomized trials related to stroke, otherwise, and there's some Lazarus is a stroke treatment technology, but it's not part of this talk at all. Those are stroke trial grants. So, brief background, right? Leading cause of long-term disability in the U.S., fourth leading cause of death. It's actually a larger cause of death in developing countries. Huge estimated direct and indirect costs. The numbers are going through the roof as our populations age. And so I'd like to start with just a brief case where I can highlight some of the techniques that get used to give you an idea and sort of show you what my standard is. So this is a woman who comes in, she's 47 years old. She has a mechanical valve, it's a known thing. Her INR is therapeutic, she's 2.5 on her Coumadin. But her night stroke scale is 14, she has a dead hemiplegia and neglect. This is her CTA. Because I'm a neurosurgeon, my radiology colleagues help me out with an arrow to show me where the problem is, so I know where to go. And you can see there's a T occlusion where there's some flow getting by it, whether it's collateral or sort of TIMI 1 or 2A kind of flow, but she's got a DETS defect as a result of this. So you can also look, it's kind of fuzzy and irregular, which to me made me worry right away that this was going to be problematic. Here I do CT perfusion, I'll talk about that in a second. We do CT perfusion in Vanderbilt. This is what the picture looks like. She has a little bit of stroke anteriorly, but most of the territory is salvageable and we feel it's worthwhile to pursue. So this is my first line. This is what I tend to do right away. And I'm going to start with that. And I'm not going to advocate that one is better than the other. I'll tell you probably, I'm actually 100% confident that Joey does more stroke than I do. And he has a different mechanism by which he does it, and he gets equally, or if not better, good results. But the point is that you have a methodology that you do, that your techs know, and that you're doing, and that's your foundation, and that's what you're going to do essentially every time. And that foundation allows you to be fast, because as we'll talk about in a second, time is of the utmost in this care. Now, never rush for rushing's sake. If you're rushing just to try to be fast, then you will do something wrong, and you'll end up causing more damage than benefit, or certainly not helping. But you should be fast because you know what you're doing, your team knows what you're doing, and you've worked out all the steps of efficiency. For those of you that came by my table, for some of you I talked about some of those things that I'm always thinking about. How do you hand the coil to the person that's next to you to maximize the efficiency so that there's no fuss? How do you plan your case as you're approaching it? This is what I do. So patient gets on the table, whether they get anesthesia or not, I am not a zealot either way. I do not believe the patient shouldn't get anesthesia. I don't believe that they should get anesthesia. I tend to go either way. We're a level 1 trauma center. We have neuroanesthesia present in every case. And because we're a large trauma center, they're very good at rapid intubation. So if the patient is moving around a lot, if they're swirly, if they don't understand what's going on, I have very little problem saying go ahead and intubate, but it needs to be done in 5 minutes. And the blood pressure can't go below 160. And as long as you do those things, I don't believe that that is a detriment. If you look at the literature that talks about anesthesia use, it's almost always related to hypotension that occurs on induction and extreme delays. 2 of my friends, who are the biggest advocates for not using anesthesia, when I actually talk to them over beers about doing it, they say, well, when we call anesthesia, it's an hour delay. Well, of course you're going to have worse outcomes because they don't do the same thing all the time. We don't use general anesthesia for every case, but they're there. So that whether we use it or not, it's not a huge time differential difference in what we do. But either way, the patient gets on the table, needle in the leg, immediately go over the long wire. We don't bother with, normally I do a program at the beginning of every case. As long as there's no challenge with access, wire goes straight up to the arch. Put a neuron max as the sheath right up to the arch. At which point I put a 125 centimeter VTEC. If you guys don't know what that is, it's a short, stiff sort of shepherd's crook catheter. There's different versions of it. I like the Cook one. It's the stiffest because I want it to be stiff. And then you click over the arch. I do that every time. Yeah, sometimes you could use a verb. Sometimes you can use various slip cath. You can do all kinds of things. I like that because no matter what the arch is, whether it's type 3 or type 1, I can click into the origin of whatever the vessel is that's a subsequent thing, and I can do it every single time the same way. As soon as I do that, I do a single sort of, depending on what I know from the CTA, either a roadmap or a puff or something, to see the neck and where I am. And I use an 038 exchange glide wire, and then put that up directly into the internal. Now, if the patient has carotid disease, which we'll discuss later, then you have to deal with that first or evaluate how you're going to deal with that. But I've had a CTA from arch to vertex for planning, so I know what the anatomy looks like. Put the 038 directly into the internal. The VTEC stays in the arch, just barely engaged, just proximally engaged in the vessel. The 038's up. With that construct, you can climb the neuron max. I don't care what the anatomy. I mean, there's always going to be some triple loop thing that won't happen, but 99.5% of any type of arch, you will be able to get the neuron max to track over a VTEC in an 038 glide. So you can go directly up to the internal. My first run is that target head run or that vert run to look at the target lesion, at which I use a Fathom. It's a 16 wire. It's very navigable, very good wire. Someone else mentioned it earlier for, I think Outstar mentioned it for bringing his XT27 up. So I use a Fathom. It's 16. It's got some good stability. It's easily steerable. It's most like a Synchro 14. It's like a bigger Synchro 14. And a 3 max and an ACE. I like that combination. There are some people who will use a velocity. There are some people who will just take the ACE directly over the Fathom. Again, I want to do the same thing every time and never run into problems. I don't want to have it get caught up at the siphon. So by having the 3 max, that's the most robust inner catheter I can have inside the 5 max. With that combination, there really has never been a time, and I can't think of one in my fellows here, to be honest, I cannot think of a case where I couldn't get the ACE into the MCA. It just doesn't, it's easy. It's not something you work on. With the Fathom and the 3 max inside the ACE, it goes up every single time. And it goes up quickly. And so that's what I do. It's the same thing every time. My techs have already had it all pulled. They're already hooking up all the drips. It's all set up, and we fly. Not because we're trying to rush, but because we're extremely efficient and fast. Now, you know, Joey can talk about his setup, and I bet he does the same. It's totally different tools, but I bet it's the exact same concept. That when he walks in the room, the techs have already pulled the stuff, the drips are already getting set up while he's getting access. The techs, my techs or fellows, if they have already put the 3 max through the 5 max and the Fathom, it's all teed up and ready by the time we have access. So Julie,
you actually flush to the 3 max and 5 max.
Yes.
Just there.
I put them both on a flush. With catheters that big, I really worry about it because, so let me talk about the subsequent steps, but I put the wire through the clot. I do not put the 3 max through the clot. So if you look at the original adapt paper that they wrote, they described Quill uses a velocity, which is fine, but why not go with the bigger catheter? So I use the 3 max. And he brings the velocity through the clot, whereas I do not. I stop before it. Dave Fiorello, who's become an advocate, he stops before it as well. In fact, he likes to suck onto the clot face a little bit with the 3 max as he brings the ACE up, and he feels he can like pull it in a little bit. But so the 3 max just goes up to the clot, but doesn't cross it. But the point is whenever you pull it, like for instance with the 5 max ACE, when you're pulling the 3 max out, there's so much volume of catheter you're pulling out, and the catheter is against the clot, so you're not filling it with blood. So your ability to suck air is actually very high. So I like to do them on drips. And then get the ACE against the face of the clot, suck on it, and then pull it out. So that's my first line. This is actually a case of Quill and Ray's. I don't know which one did it. Probably Imran. They present all the talks, but Imran does all the work. But here they bring the wire up. That's a velocity microcatheter right here on the wire, and then here's the ACE. And so you'll see there's their neuron max, which is another key point which I'll highlight in a sec. But you see, very easy. And this is over a velocity. And look, they haven't even crossed the clot. They're just coming up to where the clot is. It really navigates extremely well. So with that triaxial system, it's really not a problem. Another thing I'll highlight is the neuron max at the Petri segment. Before I do the aspiration, I try to always bring the neuron max up into the Petri segment. It essentially affects an occlusion, like a balloon occlusion. You're right there, and I aspirate on that as I'm pulling out as well. So anyway, so that's that technique. Now I want to briefly talk about some other ones, and some other guys are sort of more well-known experts. This next technique is I like to use. So this is this is my second line. So if I do aspiration 2 or 3 times, it doesn't work. I'll tell you that for me personally, it probably works 75% of the time, just the aspiration. I have great colleagues who I respect a lot, who, for whatever reason, they feel it works 50% of the time. That's okay. But you need your second line thing. This is my second line thing. So I already have the 5 max. Oh, the arrows got marked off. Just in your mind, shift those arrows down about half the screen. But
Patient moved.
Yeah, exactly. Patient moved. We were doing this one awake. But what we'll do is have the ACE before the clot, approximately, and then deploy the stent triever. So this is solitary deployed across the stenosis. You can see the run here showing the clot trapped in the stent and the flow going by. Now at this point, there are 2 different schools of thought on what to do next. I like sort of a sandwich technique. So it's adapt with the stent triever as well. So I'll go on aspiration, advance the ACE until I engage the clot and the aspiration stops, so I have that additional suction on the clot, and then I will pull both of them out. And that gives me this kind of a picture, which I have a number of those. And so that's my sort of second line technique. I have tried, this is the other technique. This is from the MUSC guys, but what they like to do is put the stent triever and then pull it fully into the aspiration catheter and pull it out. I've tried both techniques. When stent trievers first came out, before we had figured out using the adapt technique as a first line, I was using stent trievers on every stroke. And so I was experimenting with both techniques. For me personally, I like that sort of sandwich, pull them both, and they navigate so well, I don't feel like I lose more than 30 seconds going back up if I need to. And I just didn't see good success with pulling it into the ACE. Again, there are lots of people who say that is the way to go. So I'm sorry, I know you're a stent triever. What do you do?
No, I do what you do.
You pull them both together out? Yeah.
Yeah, I like the idea. If you go back to your picture and you think when you show it on, look at the clot burden there and think about pulling that into the 5 max.
Yeah.
Right, as big as the 5 max is, also the clot burden is enormous.
Yeah.
So I like the idea of whether it's your neuron max or balloon back catheter, pulling into the largest bore count.
What we ended up doing over the years after experimentation is really not have an intermediate catheter. If we go with the stent triever first, which is what we tend to do, just put the neuromax up as high as we can, navigate the stent microcatheter through the clot, put down the stent triever without an intermediate catheter, so that you don't have shearing off a problem with the intermediate catheter. Because we did that initially, and we found that many times we had fragmentation or less effectiveness of the retriever.
Are you using but you're not even using a balloon guide either.
Most of the time.
What do you guys are? I know you like the Salumber type technique here. What
Similar to that,
the sandwich or the pulling in?
Well, I'll do what you do is adapt first, and I guess I've been crossing the clot less than before, and see if you can just grab it.
Yeah. You really don't need to cross it with almost anything, as that video showed. I mean, it'll as long as you get your 3 max and your wire right up there, the ACE will come up right to the face of the clot.
I guess the thing that I found is you go up to the clot, and when you're engaged, you're not getting any flow back. That's how you know you're engaged. And then you turn on your suction, and if you don't move the ACE, and all of a sudden you get this big red, beautiful pool in your bucket, you've cleared it.
Yeah. So so talking about that technical component, I think the key to making that adapt technique, that aspiration technique work, is after you're against the clot and you've pulled your stuff out and you're on aspiration, I then advance the ACE. I push it, nothing on it, directly against the face of the clot, a good 5 millimeters or 3 millimeters. I mean, I see it move. It's not just put a little pressure. You see it advance over the clot on aspiration with nothing in it. I've never seen an intracranial dissection from that whatsoever. And I mean, that's whatever my own is, 40 adapt cases or 50 adapt cases. So it's not, certainly it could happen, but I've never seen it. That is, to me, the key. You sort of cork it as you're going over. That's when you really get it. The other thing that I've done is I've become more patient. Especially now with the ACE, with the bigger bore, I'll wait about 2 minutes of it just sucking on it before I pull. And a lot of times, like Lucas just said, it'll just go and it'll clear. Like you'll see the first one won't be flowing, and then you'll get little staccato flows, and then you get more staccato flows, and then it'll shoot through. But for the most part, still, I'm pulling it out as a full piece without crossing it with the aspiration stuck on the proximal end. But advancing it that extra few millimeters makes a big difference. So,
When you're scanning with your stent retriever with the FAANS,
yes.
when you have your FAANS on number suction and then you're manually aspirating out of your AANS.
That's correct, the Neuromax, yes. So I have a 60 cc syringe on the truth is with the 5-max in, you can't really aspirate on your Neuron Max until you're almost out. But I do that anyways in case there's anything stuck on the end or something, so that the moment I do that, I'm sucking everything out. And it's not infrequent that I get clot, organized clot in that syringe, which I immediately pour out to check. But I bet most of the time that organized clot in that syringe is coming from the end of the 5-max as it pulls through the copilot.
One thing I find with the Neuromax is frequently as you pull the things out and you don't see a clot, but you have to detach the hub.
Yeah.
Because the thing is going to be stuck in the hub. You have to make sure, because a couple of times we almost re-injected something.
Well, that's a good reason why I use the 60 cc to really clear that. Always make sure you clearly backbleed everything and there's no clot in it before you do your rerun. So that's what I did in this case. So I did my usual, right? So this is what we're going to do. The techs know it. We fly. 3-max, 5-max ACE, Fathom 16. Here's the picture. I put the low max so you can see. This is the first run I've taken. So I go up to the arch. I take a fluoro shot. So as soon as I put the sheath in, my sheath is the Neuron Max. I take a fluoro shot just to document the time, which is not what that is. But then I do this. I go direct up to the internal. This is the run. Right here, I have a fluoro shot to say when I got groin access already. And then you can see the time, just so you know I'm not lying. There's the clot. You can see all this soft, cheesy, grumacy stuff there, which I didn't know what was going to happen with that. I went up with the ACE, did aspiration, got complete TICI-3 recanalization. 4 minutes later from that first run, and 6 minutes from access. This is what came out. I mean, you could see that it was somewhat fuzzy and weird on the angio, but I mean, how ugly is that? So this is more typical of an organized clot. All this cheesy stuff, I don't know, but I was glad I was using aspiration in that case to try to pull that out. Time from the fluoro shot, as soon as I had the Neuron Max from the groin wire sheath here, I take a fluoro shot, was 6 minutes. This is her the next day, a little bit of stroke, exactly what the perfusion told us was already established red, the rest of it salvaged, she's intact. Now, I also like to show, I show this case for two main reasons. One, that's my best time, so I like to show off that I did it in 6 minutes, okay? My other is to make an important point about stroke care, okay? This lady was completely normal, essentially, a little tiny drift. They gave her 2 for facial and arm. I was a little annoyed at that, but that's the way it is. But she's essentially normal. She went home a few days later. She lived at home completely normal for the next 2 months. Remember, she had a valve. She came back 2 months later to get that valve replaced because it had been the source of the stroke. She died after that surgery. She's not alive. At a 90-day modified Rankin score outcome of 2, she's a 6. In a trial, she's a 6. So I want to highlight what that means to us when we look at these trials and we interpret them. I would call this a success. I would call this a lady who would have been hemiplegic and totally screwed, instead going home and living 2 months successfully before she then had her elective cardiac surgery and subsequently died as a success. Yet in the context of a formal trial, she's a failure. That speaks to, number one, we need to design our trials better. And number 2, these patients have a lot of baseline disease. That's why they're having a stroke. And we need to keep that in mind as we assess our outcomes and assess our trials as we move forward. So, interesting, sort of result. I show her all the time because, like I said, she's my best and I like to brag. But in the end, even though I'm showing her a success, she would be registered as a failure. So, On that note, I can't help myself. I know we're doing technical, and I'm going to talk about technical stuff. I want to talk a little bit about sort of decision making, just because this is going to be a big elephant in the room. Everyone's going to say, how do you choose your patients? I would bet there's a significant amount of variability across the faculty in this room as to how we choose our patients. And the simple answer is, we don't really know. We don't know. And I'm going to highlight why we don't know, and then I'm going to tell you what I think you should do when you're in practice. So one option is cerebral perfusion, CT perfusion. I'm a big fan of this. Right now, the Acute Stroke Working Group for the NIH, there's this huge email debate going back. All the neurologists are yelling at each other. I just happen to be on it, so I get to read them all. And
Is that in all caps?
yeah, everything's capped. Everyone's like, you're crazy. This is, you should only do an MRI. It's unethical to expose patients to radiation from the CT. And back and forth. There's all these arguments, okay? So I'm going to sort of show you what I think and what the arguments are either way. And then the real conclusion is we don't know. So I'm a big fan of perfusion imaging. This is a study that myself, when I was in Florida, so it includes my Florida series, Don Fry at Swedish, Quill Turk at NUSC, pooled our site centers. We looked at patients that we all use cerebral perfusion, CT perfusion as a selection. Patients that we treated within less than 8 hours and patients that we treated in greater than hours, 250 odd cases. And what I want to just highlight is similar, no differences in demographics, no differences in the NIH stroke scale in the cohorts, huge difference in time, which makes sense because that's how we stratify the groups. No differences in outcome, whether you're talking about independence or modified Rankin 3 or better. No difference in mortality. No difference, in fact, if anything, almost a trend towards better outcomes in the delayed patients in terms of recan. No difference in intracranial hemorrhage. So we believe that this says to us, in our hands with CT perfusion, we can adequately select the late presentation patients to mirror early prep patients. However, there's a huge contingent of individuals who say, no, time is what matters. The only thing that matters is time. It's obviously not the only thing, but that's the thing that should drive your decision making. Paper published in Lancet, looking at decreased modified Rankin scores over time, increased hemorrhages, increased mortality. Well, I believe that time is important, but I don't believe that time is an absolute. You have Pooja, who's a colleague of mine at co-PI on therapy. She's a huge it's all about time. We shouldn't waste time with any imaging. It's all about time. IMS3, she published for every 30-minute delay in IMS3, there was a 10% reduction in likelihood of good outcome. So certainly time is critical. There's a debate as to whether that should be your decided. Do you just treat everyone who shows up less than 6 hours or less than 8 hours or not? Another argument in support of time, frankly, is the randomized trials we already have. There are 4 successful recanalization-based trials. Okay, 2 for IV, that's actually ECAS-3, and 2 for intraarterial lytics. Okay, all of those trials used early time points for targets. So clearly time is important. Does that mean it's the absolute? We don't know. But they were all early intervention trials. And then here's the real rub, and this is the one that kind of bothers me the most, is everyone who says, well, it's all about the core. You have to do a DWI. The DWI core is what is real, and you look at either clinical DWI mismatch or perfusion DWI mismatch, and that's what you should do, okay? Big advocates of that. Well, this paper was just published this year where they looked at patients, this is an IA, this is IV, patients that were early recanalizers with IV thrombolysis who had gotten DWIs before. They found about 8% of patients demonstrated, they actually 17% had some DWI reversal, but then later it changed back to being positive, but 8% of patients had permanent DWI reversal. So DWI is not exactly the end-all be-all of what stroke is, we know that. Here's a case that we did just, I don't know, maybe a month and a half ago or 2 months ago at Vandy. It was a 5-year-old, was playing with his brother, fell and hit his head, probably had a very small dissection that led to a thrombus. Went to an outside hospital where he sat for 8 hours, had a basilar occlusion, came to us. We got to him 10 hours after presentation. He's nonverbal, no following. He withdraws the pain, right greater than left. Bilateral sensor planar functions. His NIH stroke scale was 22. Here's his MRI. Look at his PAANS. DWI positive throughout the entirety. This is the ADC as a correlate to show you. I looked at this and I said, this kid's dead. Like, I'm not gonna, what am I gonna do? It's ADC positive, it's not T2 shine through, this is a real thing. There's no way I can help this guy, but he's 5 years old. Like, what am I gonna, am I just gonna say he's dead? I'll try. it's probably going to ruin my series, my outcomes. You know, that's part of your threshold. Do you care more about what your outcomes look like, or do you care more about giving shots? I will lean towards giving a shot to somebody, even though they'll probably have a bad outcome and it'll make my series look worse. So I said, let's go and give it a shot. So we took him to intervention. Oh, sorry, the MRA showed the occlusion. Here's his basilar occlusion. We went up, it's in our children's hospital. We have a biplane in the children's hospital where we don't have any stroke technology. So we ran over the adults and grabbed some boxes and ran over. In this case, I used a solitaire. Because I went over, it was a kid, and I was like, oh, the vessels aren't going to be big enough, so I brought a 3 max. So I thought that would be sort of the equivalent of a 5 max. It turns out that's not the case. The vessels are just as big, basically, as in many adults. So the 3 max, as soon as I brought it up, I'm like, that's not going to work. So I switched, I had a solitaire, and I switched to use a solitaire because I brought it as a second line. And got this result. Now you can see the left PCA is still occluded. I tried a number of times to get into it, but it was such a sharp angle backwards, and the PCOM was right there, and the clot was so hard, it just kept wanting to go into the PCOM. And I did an anterior circulation run at good collaterals. I'm already getting to his contrast load limit because he's, 40 pounds. And so I said, you know what, I'd rather just leave the PCA occlusion. I think he's going to die anyways because his whole pons is infarcted on the DWI and ADC. I'm not going to give him a giant hemorrhage. If I keep poking, I'm going to poke a perforator and cause a problem. So I stopped, which I don't generally do. You'll see later I'm pretty aggressive. Yes?
I love that point that you're making. That is, in stroke, you have to have your goal set appropriately. And here, the elephant in the room is the basilar artery. You open up the basilar artery, fold, and get out of there.
Yeah. So that's what we did. I mean, I debated it a bit. In general, I try not, but what I say is this, and you'll see some later cases where I go pretty distal doing some treatments, but it's what comes easy. Don't do the thing that's hard over and over and over again. Try, if you can get it, great. I'm all about making the picture look perfect if you can, but don't kill the patient trying to do it. So anyway, so we do that, use the solitaire. He went home 8 days later, not to rehab. We haven't had a follow-up MRI, so we didn't put him back under sedation. MR2, at a 6-week follow-up, not by me, by the peds neurologist, and I had stroke scale 0, modified Rankin score 0, with that MRI. Now, does that mean that patients with that MRI are open? Absolutely not. But it means that we don't exactly know what we're saying when we say DWI is poor. And that other series I showed you was adults, not kids. So you might say, well, kids get better from everything, so it doesn't matter. This is a friend of mine's case, Don Fry. He's Swedish in Denver, 29-year-old woman, pregnant, last normal 9 a.m. She comes in with a 17. They do a thrombectomy, and I had stroke scale 5. She gets an MRI right before the procedure, and then she gets it about 4 hours later on the exact same MRI machine. We're talking 4-hour temporal difference between the pre and the post. This is the pre, this is the post. This is the pre, this is the post. So I guess what I'm trying to say is this, as is evidenced by the discussions with the faculty, is we don't really know, okay? But you need to take a good look at the literature. You need to do it with your stroke neurology colleagues. If you're that person, I feel bad for the neurologist in the room if you're going to a place where you're the interventionalist and the stroke neurologist, because I like having someone else to discuss these cases with and review them with, and so that we can come to a consensus. I feel like there's strength in numbers. But you guys...
It's good for them, because that's where we are in aneurysm, right?
Yeah.
I don't really want to clip this. I don't really want to coil it either.
Yeah, who can I send it to? Who can I send it to?
Shit.
So, but the point is you need to sit down with those people and come up with a very consistent protocol, just like you do in the angio suite. I talk about 6 minutes or 15 minutes recant or whatever. That's nothing compared to the 2 hours that get wasted in getting the patient to the angio suite. And so you need to have that system. You need to decide what you're going to do at your center, and then you need to do that consistently in an evidence-based way, as best as you interpret the evidence. That's the point of the story there. So this is what we've done. I'm not going to go into it, but it's the idea is this is decided beforehand. It's not with every patient we're figuring it out. It's done.
Did you all get that last slide?
No, but that's not. It's not the point. I'm just saying that we have something. It's more of a.
It's straightforward. It's simple.
Can you go over
It's really fast.
Actually, that's it. I want to do that. I just want to be clear. This is the decision. This is the patient. All this is just people's responsibilities. That doesn't have anything to do with what happens. This is the patient's path, and it is. It's one thing the whole way down, and there's a final decision made. There's not if-thens, there's not loop backs, there's not, when I got to Bandy, there was a sheet of paper that had like 50, like you have a curve over to here, and then you go over there, and then you might do this. It's one pathway straight down. I don't want to teach it. The point is, I'm just saying have one of these, however you make it. Now I put you to sleep with that talk, and I want to get a picture of my kids in for this. So let me talk about some decision making real quick, and you guys can stop me whenever you think is appropriate. But this is actually a case I did in Florida. This is before some of the newer techniques we use before stent retrievers. A 62-year-old man, left MCA stroke, classic symptoms, NIH stroke scale 16, onset 6 hours. He had known severe carotid disease. His physician had put him on aspirin. After a few weeks, he's like, I feel fine. He stopped taking his aspirin, comes in with this stroke. CT scan looks good, a little bit of hypodensity. Here's the occlusion. You can see there's a little branch here that's open, but the main MCA is occluded. Here's his carotid. So, to you guys, what would happen? What would you do for this carotid stenosis as your first line treatment? Would you ignore it? Would you go by it, just kind of force your way by it work? I was recently, I don't know where I was, it was some meeting or course where we were discussing this, and people said, well, first, I know where, it's SVIN. And they were like, blow by the carotid, get by it, treat the important thing, which is in the head, and then later you can decide what you want to do down below it. In fact, they were saying that sometimes they leave it, they don't even treat it, they just leave the severe disease or even the carotid occlusion included, as long as they've opened up the intracranial.
Yeah, I've even heard people talk about going up the other carotid and across the ACOM.
Yeah.
But I'll just go first and say I really disagree with that, and my approach has been to treat that first with a stent, go through it with the guide catheter, you've reestablished flow, which is one of our most important weapons in stroke, and then you can take care of what needs to be done.
And augmented collaterals, which I think
Right, then you can take care of what needs to be done in the head in a situation where you've got flow. Any situation, whether it's a thromboembolic situation with coiling or otherwise, when there's no flow, it begets a worse and worse situation, and when there is flow, it begets a better and better situation.
No, I was just going to say that I have found myself a couple of times doing exactly what the people you referred to were saying, that you have such a terrible disease here, and the problem is, and you have a big clot in the ICA, and so instead of plowing through that, risking putting more in the head, the problem of the patient is really the let's say an M1 small piece of clot that went up there. So if that's the case, I shoot the contralateral carotid. If that's wide open and the collaterals are great, and I just show the M1 clot, I have gone through the contralateral ACOM, not retrieve, but try to lyse it there, and then I think a closed carotid in that scenario is not a disaster.
I think what you were describing is exactly what you maybe you heard Mandy or someone saying that, 'cause that's exactly what we do. In this, your problem is brain that's infarcting. It's not the picture of this horrible looking carotid. So what I do is I'll take a run high up in the carotid. If I've got good flow, I'm gonna go right past that. I'm gonna take care of the clot, and I'm gonna come back, because it's time sensitive. We focus on door to needle, we focus on perfusion. It's all about time. It's time to reperfusion of tissue that's infarcted.
What would you do? I'm sorry.
So I do the angiogram, see how tight it is to get through. If it's really tight to get through, we shoot the other side. And I will angioplasty it just to get to the clot.
Just see
if
about
I cannot get through without it. And then we bring back.
Okay.
So why do you shoot the other side?
Yeah.
It's a waste of time.
Sorry?
Why do you shoot the other side? What's that going to tell you?
Just to look at the cross collaterals in case.
Yeah, I don't.
I mean, it's a time machine. The other thing that you do with those, what I've done is, if they're really tight, to your point, just go up with a balloon real quick, open it up, and then go up.
That's what I was
give you.
so I look to see, can I pass it without doing anything to it? If I feel like I need to do something to get past it, I don't stint these. I try to avoid stinting these at all costs.
Why?
I don't like aspirin climax.
So
I would balloon it, I'd
The
go
other
through it.
The other thing is that's a great case for proximal control. If you need to go by it without stenting it, or if you just want to angioplasty, or if you want to stent it, a balloon guide where you can arrest flow, arrest the possibility of throwing emboli up, then you're either addressing it or going by it, but you at least have control.
So this is what it looked like. Is that something you would plasty first,
I
or
would
you just
angioplasty that first.
angioplasty first? What would you do, Earl? Just go by it?
Well, I don't know what
You're
is
not
in the
gonna go
head.
by it.
Yeah, I need to
Is
see
there
what the
MCA
head was.
occlusion?
Yeah, if I've got good flow and I've got MCA occlusion, I would probably go right past that, and I'd open up the clot and then come back.
think you're going
So
to dollar through that?
I'm trying.
And a lot of times you can. You're looking at a picture. A lot of times you can get through that.
If
You
you
get your guide right up to the internal.
If you look at that CTA,
So
if you look at that CTA, there's a piece of rock there. I don't know how you're gonna balloon that. That's all calcium in there. I don't know.
You only need a couple
yeah,
millimeters.
it's not. I'll tell you
You
from the
don't need a
axial, it's
perfect
not
picture.
concentric. It's not concentric calcification. It's just on the side. So I'll tell you, I'm more of the inclination of Adam. I see the CTA, you know, before the patient's in the OR, right? They're getting wheeled to the OR, and so for me, I don't think there's a time sump there to say I have the stent that I want. I've measured everything. It's all ready. It takes 2 minutes to put the stent, drop it, and then go up. And so that's what I do.
Jay,
But it's
I
good
know-
for the
I know
discussion.
you're good, but
Yeah,
it does
but-
not take 2 minutes.
That's
No,
exactly
no.
right.
If you're
There's
wait
not-
a minute.
And then
Actually,
you
I disagree
lose
with that.
You
If you're
dissect that,
if
you
you're
lost
up there,
that.
okay. If you dissect it, if you're up there, if your guide,
No, but it happens. I mean,
no, but let's talk really. If your guide catheter is already here, and you're talking about what you might spend, you know, pushing by it or anything else, the time to do all you got to do is exchange a RX stent up, deploy it, and pull it out. That really does take 2 minutes. Yeah, to do a carotid stent doesn't take 2 minutes, but the difference between you're already there and you're going to go up and treat your stroke, or you're just going to RX your stent up and deploy it, and it's already pulled and been prepped before you're getting groin access because you've seen the CTA and you've set it up, it really adds negligible time, in my opinion. Yes.
I think one problem though with the stenting is you need dual antiplatelets. You may need integralin or abciximab.
So that's a great question, and that was Joey's point before, which is a legitimate argument to not use the double antiplatelets.
And we've had patients where we drop a stent, go in the do thrombectomy, TQ3, everybody's high-fiving each other, and then the next day the stent occludes because the patient's not a Plavix responder once the integralin wears off. And
Well, yeah, that's a little bit, I don't know, but
So
if
we
you have the
move to
patient on,
angioplasty and doing thrombectomy, if you can get past it with just angioplasty.
yeah, if you have the patient on aspirin and Plavix, I personally haven't had that. I mean, a large stent, a large cath, you know, that big thing, I haven't seen that include. But just having them, the hemorrhagic risk on aspirin and Plavix, what makes me feel more comfortable with that, and I'll show you later, I've kind of moved away, but what makes me feel more comfortable with that is we do have the SARA study, which all the patients got aspirin and Plavix for intracranial stenting for occlusion, and there was not a higher rate of it's not directly comparable, but there was no higher rate of hemorrhagic events, so it doesn't bother me as much. Whereas with ruptured aneurysms, which is more like brain trauma, I'm much more worried about double antiplatelet therapy than I am with stroke.
The other thing is your stent will stay open on heparin. And Vaz and I, this is something we both agree on. I don't think we're using heparin enough in acute stroke. It is easy to immediately turn it off. It makes a big difference. When you look at the top of that slide, the external carotids are filling
look at the
great
lack
all
of
the way
flow.
up, and your internal has no damn flow. And so whatever's happening in the M1 is going to be affected by the fact that you've really got compromised flow down here. So I think you can balance an argument there where addressing the flow problem is part of your stroke therapy and is worth some risk.
As a stroke neurologist, though, I do want to go on record. I'm a big fan of your. I'm going to disagree completely. I think heparin has little to no role in acute stroke, and we should not be using it.
I'm not talking about using it
We have 340 patients that we've used acute stroke. Actually, we're just about to publish this, and our rate is comparable to any study of symptomatic hemorrhage. And what we're hanging our hats on is neurology data from 80 years ago, where we didn't even, it was a CAT scan with a completed infarct. We gave a 10,000 unit bolus of heparin. They hemorrhaged, and everyone scratched their head. So now we have imaging where we can, what heparin does is it stop. The argument is, it doesn't lyse the clot. It stops propagation, and that's where you get into trouble with a lot of these cases, where you get a great result angiographically, and then they go on, especially if you're going to put a stent or something
But
in.
I guess the question is, what are you using heparin for? Is it for your stent? Is it for your
No.
intracranial? What are you using?
We're
it
using
for?
heparin in this case. That's a great question. In two points. One, heparin is not a substitute for flow restoration, and that's the problem with the neurology literature so far. But two, if you have had thrombosis in the absence of flow and you're able to reestablish flow, heparin is critical to get that cascade going in the right direction. Three, if you have to put a metal in and you don't know if the patient is a Plavix responder or not, and you haven't started aspirin Plavix yet, heparin can temporize and you can shut it off immediately, unlike antiplatelets, until you can get them into a more stable situation.
And it also has a rheologic effect.
Okay. Well, I'll just say I'm more of Joey's. I'm cautious with heparin in these stroke cases, but I don't. The point is we don't know. So I stented it. Go up. Here's the occlusion we saw in the CTA. This is again before stent treatment. I used the old penumbra aspiration system and get. Hold on. Now I go up there. Get this result. So now the question is like for you guys, how many of the fellows? I want to see fellows actually raise your hand. Nobody not raise your hand. If you do, I'm going to fail you for the course. Raise your hand. Are you happy here? Would you stop? Or would you want to do anything further? If you're happy here or at your center, would your physicians be happy? Would you stop now, or would you do more?
I'd put a wingspan.
Raise your hand if you would stop. Raise your hand if you would do more. You're all failing if you don't raise your hands. All right. So I would, if you look here, there's still a significant MCA occlusion right there in the M2 branch. So go out, do further thromboaspiration, get that open right there. That's the final result. This is the post. Patient has a little bit of stroke, not surprisingly. Here he is doing great.
Can we either speed up or cut you off here so we can get to the lab?
Can we do one more?
Yeah.
Because it's along the discussions that we just had. So similar discussion that we just had, but a little different approach to it depending on the pathology. Right-sided weakness 3 hours after, an X stroke of 14. Left ICA is occluded, INR is therapeutic. Aphasic, some right-side movement, but not any gravity. Oh, sorry, here's the perfusion. You can see on the CTA there's a little backflow and then there's no flow here. And this is the one I'm interested to hear the group. Here's this carotid occlusion. So you have thrombus, chunks of thrombus, chunk here, all the way up and down the carotid. Now, what would people want to do here? Ansar, what would you do in this circumstance?
So, I'm sorry, I missed at the top, there's an MC occlusion as well.
Yes.
I had a case like this, and I used do you think the underlying carotid is dissected, or is it just soft?
There's not a lot of atheromatous on the CTA from the other side, so it's probably not a lot of, either it's like a ruptured plaque that's now propagated thrombus, or a very small dissection. There's no obvious dissection, there's moderate
Alright,
plaque.
so what in the case like what I did was I had a neuromax in the bifurcation. I put a filter up distant to the petrous cut base, and I used a 5-max haze to aspirate the clot out of the carotid.
Over the filter wire, up to the filter.
No, I put the, actually I had a balloon guy and a neuromax. Double puncture, and I put the filter beside it and 5-max balloon.
Anyone else?
In the case where I did do this, and I just got the entire clot out of the carotid. That's what I put the filter in.
Get rid of it then?
I cleaned the carotid, took the filter out, and then I went up through this stent.
We just put the neuromax as high as I can on suction.
And just suck, yeah, that's what I did. Any other thoughts, Joe?
I consider a balloon guide catheter induced at a big 5-max A something to aspirate proximally.
That's right, Rob. So I did what Tibor just said. I just took the neuromax and went up on an aspiration. Well, that's the max. So that's a 088 guide catheter. And these are all the huge chunks of organized clot that sort of sucked out, which was pretty cool. That said, in the bulb, there was still some thrombus sitting there. And so, consistent with what we talked about before, I put a stent down to cover that residual amount of organized thrombus. The max, I was never going to get the max to sort of go out in the bulb, and I didn't want to knock it up.
What kind of stent do you use? Closed
I use
cells?
a wall stent.
Yeah, exactly.
All right, so I'll tell you on that note, technique-wise, I really, really like the wall stent for stroke because it's closed cell, it's very retrievable, and it's really long. It's a braid.
Yeah.
So if you oversize it, you can cover a tremendous amount of length. All the other ones are cut tubes, so they just pop open to they're 40 centimeters. But if you take a 40 centimeter wall, like a 10 by 40, you can get 90 centimeters of coverage if that's what you want. So that's what I prefer for strokes.
Thermal and aspirin clot.
Yes. Yep. So here's the occlusion. And this, I just want to do this to show you you need various tools. I do adapt with the ACE. 2 poles get 2 plugs that come out on it. So now I have this, but there's this sort of distal M1, genu bifurcation clot. I do one more aspiration, that doesn't come out. So I switch to a stentriever and pull that out with the stentriever at that point.
It looks like the same clock on the last picture.
Yeah, I just took the clot and put it accidentally over. I don't know, the techs take the pictures for me, so they may well still finish it up. I'll blame it on Cal if he's in here. So, anyways, this is the result with TK3 reperfusion. She improved to a 6. Her aphasia essentially went away. I was going to put 90% aphasia for the percent issues, but her aphasia essentially went away. She had a little bit of speech delay, and she became anti-gravity, but still weak, but otherwise did well. So just hopefully this just highlighted like all the conversations that we have and the debate as far as how we do this. That's it.